بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the second part of the lecture for renal imaging. And you may remember that we have finished in the first part of this lecture some of the anatomic details and congenital anomalies of the kidney, and we mentioned also something about the stone disease, and we discussed in details the issue of renal cysts, the simple renal cyst and Bosniak classification, as well as the polycystic kidney disease. Now we are going to the second part of this lecture, and we will deal with the rest of renal masses, mainly the renal cell carcinoma, of course, and other renal malignancies. Then we'll talk about the renal trauma, and finally we'll handle some of the renal inflammatory diseases. You know that renal cell carcinoma represents about 90% of renal tumors in adults, and this is the male to female incidence. We also know that the classic triad of pain, hematuria, and abdominal mass is no more a common presentation, and as many as 25 to 50% of renal cell carcinomas may be discovered incidentally during abdominal examination for any other reason. Then in the era of intravenous urography, we used to diagnose renal cell carcinoma by this appearance, and here you can see that there is amputation and destruction of the upper ball calyces on the left side, while the lower ball calyces are intact with preserved calyceal cupping, and the right kidney is good. By ultrasound, we know that this is the normal appearance of the renal parenchyma, and this is a classic appearance of a simple renal cyst with hypoechoic fluid-containing lesion with posterior enhancement, and this is the appearance of a solid renal mass with a echogenic texture and no posterior enhancement. Then you also remember the difference between simple renal cyst, the fluid-containing lesion in the kidney, and the renal cell carcinoma, which is a solid lesion in the renal parenchyma. Then, as I have mentioned, that as many as 25 to 50% of renal carcinomas are incidentally discovered during abdominal examination. Then frank hematuria is absent in about 40% of the cases, and microscopic hematuria may be seen. Then this is the appearance of the renal cell carcinoma on IVB and CT scan. And here you see what I have mentioned: destruction and the amputation of the calyceal system in the lower part of the right kidney, with a sensation of a soft tissue tumefaction here. Then by the CT scan you can realize that there is a solid mass arising from the anterior aspect of the kidney, and the mass contains some calcific foci as well as areas of breakdown. Then these are the usual intravenous urographic findings and ultrasound as well. There may be a focal contour bulge of the affected kidney, amputation of part of the collecting system, and the renal axis may rotate depending on the position of the tumor, and there is maybe a localized hydronephrosis or hydrocalcicosis according also to the site of the tumor in relation to the pelvic calyceal system. But you know that the most the most common imaging finding for renal cell carcinoma is the detection of a solid renal mass in an adult. Then this mass is enhancing, and the enhancement is usually heterogeneous due to the presence of central areas of breakdown, and it may contain calcium, of course. And whenever you diagnose a solid mass in the kidney as renal cell carcinoma, and you have to verify these issues, and you have to mention in the report what is the state of the renal vein. Is it invaded by the tumor or not? And if it is invaded, is the tumor is reaching the inferior vena cava or not? Then what about perinephric extension? What about regional lymph node metastasis? And what about metastasis elsewhere, especially in the kidney and in the adrenal gland and in the liver as well? Then you should mention something about the tumor size, which is very important, as I will mention. In the perinephric extension, the tumor vascularity, which is seen by Doppler ultrasound or CT angiography, and sometimes you may need to embolize the tumor preoperatively. And you should mention also the presence or absence of lymph node metastasis, vascular invasion, especially the renal vein and the IVC, then local spread and distant metastatic disease. And the staging of the renal cell carcinoma is usually done by the TNM classification, and the T1 is divided into two, where T1A is a tumor mass which is less than 4 centimeters in diameter, and this mass is confined to the renal capsule, and the prognosis is very good for such a lesion. Here is the pre-contrast scan, and you see focal contour bulge of the right kidney. After contrast injection, you see that the tumor, of course, is not enhancing similar to the renal parenchyma. It usually enhances less than the renal parenchymal enhancement. Then these are the criteria to allow the surgeon to do partial nephrectomy, or what is known as nephron sparing surgery. Sometimes you have a small tumor and it is confined to a certain part of the kidney, then the surgeon may be able to excise the tumor and part of the kidney and spare the other part, which is valuable, of course, for the patient. Then these are the criteria. Number one, the peripheral location of the tumor, and the tumor is stage 1 T1A, meaning that it is less than 4 centimeters in diameter, and there is no invasion of the renal sinus fat, no invasion of the collecting system, and of course no extension into the renal vein, with no regional lymphadenopathy or distant metastatic disease. And stage T1B is that the tumor which is in the range from 4 to 7 centimeters in diameter, and here is an example, and you see a solid renal mass which is arising from the posterior aspect of the upper part of the kidney, and the mass is in the range of 5 to 6 centimeters in diameter. Then stage 2 is the tumor which is more than 7 centimeters in diameter, and in this condition you cannot do a nephron sparing or partial nephrectomy, because the remaining renal tissue is of no significance for the patient. And here you see a mass in the anterior aspect of the right kidney, and the mass is above 7 centimeters in diameter, and this arrow points to that the tumor is extending inside the renal pelvis as well. Then stage 3 has 3 subdivisions. The stage 3A is the tumor which is extending into the perinephric fat, And we used to say that a stranding of the perinephric fat is a sign of tumor spread, but in order to say safely that there is an extension into the perinephric fat, you should see some nodular lesions that are enhancing within the fat around the kidney. And invasion of the fat does not affect the management or the prognosis of the tumor. And in this case, you see a tumor infiltrating the left kidney with diffuse thickening of the Gerota fascia and the stranding of the perinephric fat. The perinephric fat stranding is not a reliable sign for perinephric fat invasion, but the presence of enhancing nodules around the kidney is important. Then stage 3B and C are dealing with invasion of the renal vein and extension into the IVC. And extension into the renal vein also does not affect the prognosis of the patient, while extension into the IVC is usually seen in about 5% of the cases, and there is a good prognosis if the thrombus is confined to the vessel lumen, meaning that it is not invading the perivascular space. Here you see the renal mass which is infiltrating the left kidney, and you see the tumor is extending into the renal vein, but it did not yet reach the IVC. Then if the tumor is has reached the inferior vena cava, as in this case, you see a renal mass, and there is invasion of the renal vein reaching the site of the IVC, then you can say that this is stage 3C. It is usually stated in the literature that MRI, because of its sensitivity for the vessels and the flow, and also it can assess the vascular structures without the need for injection of contrast media, can be more valuable in detection of vascular invasion. And here you see a mass in the right kidney, and it has extended into the renal vein as well as into the IVC. And this is a coronal reformatted CT images of a renal cell carcinoma on the left side that has invaded the renal vein as well as the IVC, reaching as far as the site of the right atrium. And stage 4A, meaning that the tumor has crossed the Gerota fascia into the paranephric space, and here you see a mass in the right kidney, and you see affection of the adjacent part of the liver with direct extension. And the presence of lymph nodes is usually an indication of poor prognosis, and this is the 5-year survival rate, which ranges between 5 to 30%. The usual threshold for the pathologic nodes is 1 centimeter in diameter, and in this case you see that the kidney is obstructed by a calculus, and there is dilatation of the collecting system, and there is a mass within the calyces, and in the para-aortic area, this is the aorta, and you see a big lymph node to the left of the aorta. This is the IVC. This is the pancreatic head identified by the superior mesenteric artery and vein. Then this is the tumor in the left kidney, and in the para-aortic area, and you see a soft tissue mass representing metastatic lymphadenopathy. Tumor with metastasis is stage M1, and this is an example. Here you see a mass in the left kidney with metastatic deposit in the liver. And common sites for metastasis are the lung, the liver, and the bones. Less common sites are the kidney, the opposite kidney, adrenal gland, and the pancreas. Then this is a tumor in the left kidney, and this patient is known to have metastasis in the lung. Then we came to the issue. You remember that the Bosniak category 4 is a cystic lesion with enhancing solid component, and this is Bosniak category 1, simple renal cyst with clear water contents, sharp well-defined margin, no internal septation, no calcification, no mural nodules, and no enhancement. And this is an example of Bosniak stage 4, or what we call cystic renal cell carcinoma. You see a big cyst in the right kidney with multiple enhancing mural nodules, and this is a cystic renal cell carcinoma. You see here a big mass in the region of the right kidney, when the mass contains a cystic component and a multiple solid mural nodules. This is Bosniak category 4. And this is also a cystic renal cell carcinoma by CT post-contrast, coronal reformatted image, and CT renal angiography. The tumor is mainly cystic with a small solid component, and you can appreciate the tumor vascularity in the angiographic image. And you should know that also the renal cell carcinoma, as well as the bronchogenic carcinoma and the hepatocellular carcinoma, can show gross calcification. And this is an example. This is the right kidney, which is pushed downward by a huge mass arising from the left kidney with extensive calcification inside. Then we came to a solid lesion, which is seen in the pediatric age group, and this is Wilms tumor or the nephroblastoma. This represents about 7% of all pediatric cancers, and is the most common primary malignant renal tumor of the childhood. The mean age for diagnosis is about 3.5 years of age, and the main presentation is by abdominal mass, and sometimes the patient is complaining of pain, fever, and hematuria. Then the 10% of the cases have metastasis at presentation, and you should remember that Wilms tumor can occur bilaterally in about 5 to 10% of the cases. This is an example of Wilms tumor in the right kidney, and there is a huge mass in the pre-contrast scan, and after contrast injection you see heterogeneous post-contrast enhancement. And in order to know that this mass is of renal origin, there is a good sign which is known as the Clow sign. And by the Clow sign, I mean that there is normal renal tissue extending along the border of the tumor in appearance like a tongue-like process or so. Then you know that this lesion is originating from the kidney, not originating outside the kidney and infiltrating the kidney. This tongue-like projection, or the Clow sign, is one of the important findings to appreciate that this tumor is of renal origin. And here is a male child, 3 years old, with a big mass in the left kidney in the axial, coronal, and sagittal reformatted images. The renal lymphoma is also a known malignancy, and it can occur in patients known to have lymphoma, or in cases who are immune compromised. And in order to diagnose renal lymphoma, it is a solid mass that is not differentiated easily from renal cell carcinoma. But if you see that the renal mass is multiple in the same kidney, or in the opposite kidney, or bilateral multiple renal masses, and this favors the diagnosis of lymphoma. Number 2, the renal masses do not deform the renal contour, and you see they are not bulging like the renal cell carcinoma. Number 3, if you have other positive findings to support the diagnosis of lymphoma, like the presence of solid focal splenic lesions. You remember that the most common solid focal splenic lesion in adults and in children is lymphoma. Then this is lymphoma, and lymphoma in the liver, lymphoma in both kidneys, and also there are some lymphadenopathy in the abdomen. And this is also a case of lymphoma, bilateral renal, solid renal masses, and the masses are more or less do not deforming the renal outline. Then this is also a case of lymphoma. Both kidneys are enlarged. They are infiltrated by multiple solid masses compressing the collecting system. Then we came to the urethral tumors, or the transitional cell carcinoma, which arise inside the renal pelvis, the ureter, or the renal bladder. And this is the most common renal pelvic tumor. In multiple lesions are common, occurring in about 30% of the cases. So whenever you are diagnosing urethral tumor in the renal pelvis, look carefully to the ureter and to the renal bladder and to the opposite kidney for multiplicity. The incidence is 4 times to 1 in male and female, and is usually in the old age. The helpful diagnostic tool is that which can show the collecting system good, and this may be obtained by intravenous urography, CT urography, and MR urography. The main diagnostic finding is the presence of a solid renal pelvic mass which is not mobile. And you see a mass in the upper calyces and reaching the renal pelvis, and the mass is well seen also in the axial images, and this is diagnostic of transitional cell carcinoma. This is an example. You see the renal pelvis by intravenous urography, and there is a huge mass involving the lower ball calyces as well as the renal pelvis and the upper part of the ureter. Diagnostic of transitional cell carcinoma. And this is a mass obstructing the renal pelvis on the left side with dilated calyces, hydronephrotic kidney, and after in the delayed images you see the calyces are filled with the excreted contrast media, and the mass is distending in the renal pelvis. Diagnostic of urethral tumor. Ultrasound and CT scan, and here you see a mass in the renal pelvis with proximal dilatation of the calyces, as you can see here. Then, as I mentioned, that transitional cell carcinoma may occur at multiple sites, and here you can see a lesion in the urinary bladder, and you can see also a lesion in the proximal part of the right ureter, and a third lesion which is seen in the renal pelvis on the left side. And this tumor can also invade the renal parenchyma, the perinephric fat, and may extend into the renal vein. As you can see here, this is the tumor within the calyces with the tumor thrombus into the renal vein reaching the IVC. Then what are the possibilities for a pelvic filling defect? Of course, if this defect is mobile, then you may consider radiolucent stones or blood clots. But if it is not mobile, then you consider transitional cell carcinoma, polyps, hypertrophied renal papilla, maybe sometimes vascular impression, and some of the inflammatory conditions. And the kidney is not immune from metastatic disease. And sometimes you got this patient with ovarian cancer has a solid renal mass in the left kidney, and in the presence of a known primary malignancy, then you should think of renal metastasis. And these metastatic deposits are somewhat commonly seen in autopsy series, and the incidence reaches 12%. And many lesions are microscopic, but some lesions are macroscopic. Then this is a pulmonary carcinoid tumor with some pleural effusion, and he got metastatic deposit in the left kidney and also another one in the right kidney. And the solid renal masses are commonly malignant, and there is some solid renal masses that are benign, and this is one of them, which is the oncocytoma. The oncocytoma is a benign solid tumor, and it represents about 3 to 5% of the renal tumors, and usually is asymptomatic. Sometimes this tumor is multiple, and many times the tumor is very large, and it may appear as a bulky mass in the kidney, as you can see in this example. And here the close sign, which is extension of the enhancing renal parenchyma along the border of the tumor, and you see a big tumor which is solid, and this central scar or non-enhancing scar is considered by the literature as one of the pathognomonic findings for oncocytoma. But many times you cannot see this scar, as in this case you see a solid mass in the right kidney which is less enhancing than the normal renal parenchyma, and on angiography you see the marked hypervascularity of the tumor, and this has been proved to be an oncocytoma, not a renal cell carcinoma. This is an oncocytoma, a solid mass in the kidney, and the enhancement later on, but this is the early enhancement and this is later enhancement. We usually diagnose this as renal cell carcinoma, which is much more common compared to the oncocytoma, but on biopsy we may get this result, which is the oncocytoma. And this is an oncocytoma in the left, in the right kidney. You see the scar, you see the tumor, and to be differentiated from renal cell carcinoma is a difficult task. However, the diagnostic criteria, the homogeneous solid lesion, renal cell carcinoma is also like this, a sharply hypodense scar, which is only seen in 1/3 of the cases, and the rest of the cases do not contain a scar, and a large size of the tumor, and the renal cell carcinoma also may reach a large size. Then we came to another lesion, which is known as multilocular cystic nephroma, and this lesion is of unknown origin. It is a big lesion with multiple internal cystic structures. It occurs in children as well as in adults, and the cystic lesions have thick internal septations, and if you remember, this was considered as category 3 Bosniak classification. Sometimes you see calcium in these lesions. And this is the classic appearance of multilocular cystic nephroma by ultrasound and by CT scan. You can see very well the close sign or the extension of the enhancing renal parenchyma along the border of the lesion with multiple cystic lesions as well as internal septations. And once more, this is a female child, 17 months old. And you see a lesion, big lesion, cystic lesion in the kidney with internal septations, and this is the appearance by the non-contrast CT scan of the abdomen. If you see a fat-containing mass in the kidney, consider angiomyolipoma, because this is the most common fat-containing lesion in the kidney. However, other fat-containing lesions in the kidney may represent lipoma, teratoma, liposarcoma, and this inflammatory condition, which is known as densogranulomatous pyelonephritis. Then you should remember that a fat-containing lesion in the kidney should represent angiomyolipoma until proved otherwise. And these masses are usually asymptomatic. They are more common in females compared to males. They show heterogeneous enhancement according to the solid component, and the fat is the most diagnostic landmark. Here you see the close sign indicating that this lesion is arising from the upper pole of the kidney and not from the suprarenal gland, for example. Then if you see a lesion which is clearly identified in the pre-contrast scan, you should not diagnose this as simple renal cyst, and you should consider that it is of fat density. Then after injection of contrast, you realize that this is fat with some internal shadows inside, which may represent the myomatous or the vascular component of the tumor. My advice is not to biopsy fat containing lesion in the kidney by ultrasound or guided CT needle biopsy, because this lesion is most likely an angiomyolipoma. It will bleed, then you will not be able to control this bleeding. And then one of the helpful tools for confirming the diagnosis of angiomyolipoma is by angiography, whether this is obtained by CT or by MRI, or even by selective angiography prior to embolization of some of the large lesions. Then renal angiomyolipoma is one of the common features in this particular disease, the tuberous sclerosis, and you know that 40 to 80% of patients with tuberous sclerosis have angiomyolipoma. And if you remember the chest lectures, I have mentioned the cystic disease in the lung, with numerous small cysts distributed throughout the renal parenchyma in cases of tuberous sclerosis, as well as in cases of lymphangiomyomatosis. Then in tuberous sclerosis, you see cystic changes in the lungs, as well as angiomyolipoma in the kidney, which may be bilateral and huge, as you can see here on both sides. And this is a case of tuberous sclerosis, showing a large angiomyolipoma on the right side and a large angiomyolipoma on the left side. Also, you may see small angiomyolipomas in the liver as well, and this is the simple cyst in the liver. You can appreciate the difference between fluid in the cyst and fat. This is of course a pre-contrast study. The fat is much more dark, even it is present in a very minute foci like this. Then angiomyolipoma has a tendency to bleed because of its vascularity, and this is an example of bleeding angiomyolipoma on the left side. Still, you can identify fat, which is essential for the diagnosis of angiomyolipoma, but this huge shadow circumferentially surrounding the kidney or the tumor is the bleeding from this big angiomyolipoma, and you can see a small angiomyolipoma on the right side. Then we came to the renal trauma, and I mentioned some hints about the trauma. I have discussed this issue in details in the lecture of abdominal trauma. And the different types of renal trauma include the subcapsular hematoma, the perinephric hematoma, renal contusion, renal laceration, and the shattered kidney, as well as avulsion of the renal vascular pedicle. And you see this is an example of renal contusion, and this is superficial laceration, deep laceration reaching the pelvic cell system, and shattered kidney with multiple lacerations and a large perinephric hematoma. And this is a subcapsular hematoma, which is confined to the renal capsule around the enhancing renal parenchyma. And one of the common causes for this subcapsular hematoma is the biopsy techniques. Then perinephric hematoma is a larger hematoma which will extend outside the renal capsule into the perinephric space. And here you see a good amount of blood displacing the kidney anteriorly. And here you see there are multiple non-enhancing shadows within the renal parenchyma representing renal lacerations together with a huge perinephric hematoma. Then you remember this case of a child that tried to get something from above a shelf, then he fall on his side on the table, then he got severe hematuria. Then the CT scan without contrast showed a swollen left kidney, and after injection of contrast, you may see minute enhancing renal parenchymal tissue surrounded by a large perinephric hematoma. And the reconstructed images showed that there is avulsion of the lower renal bowl with a large area of perinephric hemorrhage, as you can see. Then whenever you have this picture, which is pathognomonic, after injection of contrast for a patient with blunt abdominal trauma, you see one kidney is enhancing and the other kidney is not enhancing, and this is diagnostic of avulsion of the renal vascular pedicle. This kidney is well nourished by the blood supply, and here the blood supply is not reaching the kidney, and you can confirm this by renal angiography, usually done by CT, and previously was done by flush aortography, for example. This is a case of avulsion of the renal vascular pedicle on the left side, and you see the left kidney is not enhancing and the right kidney is enhancing. Then we came to the renal infection, and I would like to say something about the acute pyelonephritis, chronic pyelonephritis, renal abscesses, and the perirenal abscesses, the renal TB, emphysematous pyelonephritis, densogranulomatous pyelonephritis, and finally the renal hydatid disease. Acute renal conditions like acute pyelonephritis, acute glomerulonephritis, and renal vein thrombosis will manifest by fixed appearances, including a swollen kidney with poor renal function, relatively poor renal function, and the dirty appearance of the perinephric fat. Then if you see that the kidney is swollen with a striated nephrogram, and this is what we call a striated nephrogram, and this is diagnostic of acute pyelonephritis. And you see here, this is the kidney which is swollen compared to the opposite side, and you see the striation of the nephrogram, and you see the dirty appearance of the perinephric fat, and you see the thickening of the Gerotta fascia, and this is a case of acute pyelonephritis. The classic appearance of a striated nephrogram on the left side with a swollen kidney compared to the opposite side, diagnostic of acute pyelonephritis. And this is acute pyelonephritis on the left side with developing renal abscesses, and you see these areas will have the degenerated and liquefied to form renal abscesses. Urinary tract infection occur in about 30% of the girls and 1% of the boys, and the early diagnosis is important to prevent the chronic stage of acute pyelonephritis with renal scarring, and which may proceed to renal failure. Then this is the chronic pyelonephritis. The kidney will develop some scarring in the renal parenchyma, and by time it will lose its function. And how to appreciate the presence of chronic pyelonephritis, you look to the collecting system, and if you see that the calyx is almost approaching the renal capsule, meaning that the intervening renal parenchyma is scarred. Then if you see this finding, this is one of the good supportive signs for the diagnosis of chronic pyelonephritis. And this is a urogram obtained by MRI, and you see on the left side there is good renal parenchymal thickness, there is a good distance between the calyces and the renal capsule. But on the right side you can see that the calyces are clubbed, they are dilated, the pelvis is distended, and the ureter is also distended, when the renal parenchyma is markedly scarred in this area, and you still have some of the functioning renal tissue in the upper and lower bowl. The dilated ureter, of course, point to the possibility of zygoreteric reflux, which is one of the most common causes of acute and chronic pyelonephritis. This is the left kidney, which shows normal fetal lobulations. These indentations lie between the calyces, but this is a chronic pyelonephritic kidney. The kidney is very small, the renal outline is deformed with scar tissue here and there. The renal abscess is the development of an abscess inside the kidney. It is the sequelae of urinary tract infection, the trauma, or urinary tract obstruction, or maybe by hematogenous spread. Like any abscess anywhere, it will appear as a cystic lesion with a thick enhancing margin. The surrounding renal parenchyma will show some hypodensity due to perifocal edema, and also air loculi may be identified within the abscess, which may extend sometimes into the perinephric space. And this is a perirenal abscess. The kidney contour is almost good, and the renal parenchymal thickness is preserved, but you see thickening and enhancement of the perinephric fascia fluid and extensive air loculi, diagnostic of perinephric abscess. And this is renal abscess in the right kidney, a large cyst-like structure with thick enhancing margin. You should remember that simple renal cysts do not have a thick margin and do not show contrast enhancement. Then TB can affect the kidney, and genitourinary tuberculosis is the second most common after the TB of the lung, and it affects more males than females, and usually spread by hematogenous route. And then many times the patient may have pulmonary and urinary tract tuberculosis in about 25% of the cases. Active pulmonary TB is seen only in 4 to 8% of the cases whenever you diagnose renal tuberculosis. The pathognomonic signs for diagnosis of renal TB are two. Number one is the calyceal stricture. Number two is the presence of renal parenchymal calcification. Then if you see this stricture, which is one of the classic appearances of TB of the kidney, and the early signs, you see a stricture and you see renal parenchymal calcification. These are the most two pathognomonic signs. And if you are in the exam and you are going to diagnose renal tuberculosis, look carefully to the adjacent spine, because there may be, as frequently seen in exams, a TB of the spine as well. Then it will help you to reach the diagnosis and to collect some more degrees. Then here, this is the kidney, which is good, and here you see an amputated or a stricture in the calyx, and this may suggest the possibility of tuberculosis. But if you see extensive calcification like this, and this is what we call autonephrectomy, the kidney is very small, it does not function, and is almost totally calcified. And here is what we mean by autonephrectomy. The right kidney is totally calcified. This is a non-contrast study, and it's relatively a small kidney. Then we came to the xanthogranulomatous pyelonephritis, which is a rare form of chronic pyelonephritis. And here the kidney is infiltrated by lipid-filled macrophages. The kidney will be very large sometimes, and there is one of the landmarks for this pyelonephritis is the presence of a big stone in the kidney, together with an extensive areas of fat deposition, together with almost loss of the function of the kidney. Then you see a large obstructing calculus in about 75% of the cases, and large non-functioning kidney, and the fat which is infiltrating the renal parenchyma. This is a very good example of xanthogranulomatous pyelonephritis of the left kidney. You see the kidney is huge and the kidney is not functioning. There are big calculi, and there is a good amount of fat replacing the renal parenchyma. Sometimes you cannot see this triad, which I mean the fat and the loss of function and the stone, but you may predict the appearance by the presence of two. If you see a big calculus and you see fat, and this is These are supportive signs. As I have mentioned, this is a rare variant of chronic pyelonephritis, usually affects a single kidney, and most common in the middle-aged woman with history of recurrent urinary tract infection. And here you see, if you say that this is an acute pyelonephritic kidney, this is good for the diagnosis because of the presence of multiple liquefied areas representing abscesses. But if you can elicit the presence of fat or a big stone in other sections, then you may go to the diagnosis of xanthogranulomatous pyelonephritis, which is also seen in patients with diabetes. The treatment of this type of pyelonephritis is by nephrectomy. Emphysematous pyelonephritis is the presence of gas in the collecting system as well as in the renal parenchyma and also in the perinephric space. This emphysematous pyelonephritis is usually seen in diabetic patients, and it indicates a severe type of inflammation. And here, a non-contrast study of the kidney, the right kidney, shows extensive air within the renal parenchyma and the peri and paranephric spaces, diagnostic of emphysematous pyelonephritis. And finally, we have a few words about the hydatid disease, which can also occur in the kidney. I presented many examples whenever I talked about the hydatid disease in the liver and the spleen, and I show some examples affecting also the kidney as well. And this is an example of hydatid cyst in the right kidney. He diagnosed the hydatid cyst by one of three criteria. The first one is the presence of a large cyst with multiple mural internal small daughter cysts. This is one of the classic pictures of hydatid disease. Or you see a cyst with floating internal shadows, and this is also pathognomonic for hydatid disease. And the third one is not for the kidney. If you see a cyst with mural calcification, then you consider Bosniak type 2. And you do not consider hydatid disease. But if you see a cyst with marginal calcification in the liver or in the spleen, you may diagnose this as hydatid cyst. And this is hydatid cyst in the left kidney. You can see the claw sign, which is pathognomonic for renal origin of the cyst. And you see multiple mural cysts within a big cystic lesion, diagnostic of renal hydatid disease. Alhamdulillah Rabbil Alameen. Thank you very much.